Hello and happy Tuesday. My name is Lisa Houston. I am a NICU nurse educator, and today for our Teach Me Tuesday, we are going to talk about hypoxic ischemic encephalopathy. As you may know, April is HIE Awareness Month, and so we are going to spend the last 2 Tuesdays of April diving deeper into HIE. We have previously covered this about 6 months ago, and it was more of a surface level and put everything together, but we're going to break this into 2 parts, which is kind of what contributes to HIE and how do we diagnose it is what we're going to talk about today in part 1. And next week in part 2, we're going to really talk about the treatment for HIE, specifically about cooling and then other treatments that are available out there now. So let's start by digging in to what is HIE. So hypoxic ischemic encephalopathy. I gotta be honest, I don't like saying it, but I don't like seeing babies with it. It is tricky. So when we talk about hypoxia, that means the baby's blood doesn't have enough oxygen. There's a lack of oxygen in the blood. It can happen from a variety of things in which we are going to kind of dive into, but I do want you to remember that HIE has a lot to do with my favorite organ, or my favorite temporary organ, or as I like to say, the greatest temporary organ to ever exist, and that is the placenta. So you can imagine that if the placenta has anything going on with it, even if it cannot exchange the carbon dioxide and oxygen appropriately, then the baby's blood will have a lack of oxygen in it. Ischemia is the lack of blood flow to tissues, and in this case, we would be talking specifically about the brain. So not only do we have a lack of oxygen, but now we have a lack of blood flow. And so then you can imagine that the blood that is even getting to the tissue, in this situation, the brain, is going to be deprived of oxygen. Encephalopathy is kind of an umbrella term. It's just a big word that covers any damage or disease that affects the brain. It's the functioning of the baby's brain. If something goes wrong there, that would be characterized as encephalopathy. So we have the H, which is hypoxia. So hypo always means low. And then we've got oxia, which is oxygen. So low oxygen in the blood. Ischemia, which is the lack of blood flow. So in this situation, we're thinking blood cannot get to the brain. We are not able to perfuse the brain, which causes brain damage or encephalopathy. So we ask ourselves, kind of, why do we want to look into this? Why do we focus so much on this? And that's because HIE is probably much more prevalent than you think. In the NICU I currently work at, we probably do total body cooling at least once a month, so a total of about 12 to maybe 18 babies every year. On average, our our hospital would deliver about 10,000 babies a year, and then our NICU sees about 1,200 patients. So it kind of, falls into that category of, 2 to 3. Some statistics say 2 to 4 or 2.4 per 1,000 live births are diagnosed with HIE. When you think about the whole entire world, birth asphyxia is the cause of 23% of all neonatal deaths. The statistics for HIE in developed countries versus developing countries are pretty startling, which we're going to talk about a little bit when we talk about kind of what complications lead us here. It is the 5th leading cause of death in children younger than 5 years of age. It accounts for 920,000 neonatal deaths every year and is often tied right in there with intrapartum stillbirths. So a lot of these things we're going to talk about, especially like nuchal cord, true knots, placental insufficiency, oftentimes the baby dies in utero before they make it out, so that would be your intrapartum stillbirths. And then HIE is also the leading cause of neonatal seizures. So let's talk about why are all these things happening and what can we be looking for. So first we're going to talk about the placenta. So what are the placental complications that lead us to thinking this baby is at risk for HIE? I want to start off by saying that everything we're going to talk about today in relation to complications are risk factors. It doesn't mean that every single time you have placental previa, placental abruption, the baby will have HIE. It just increases their risk and their chance of having HIE. Because the placenta is the workhorse of the pregnancy, any complications with the placenta contribute to your HIE by increasing the risk for hypoxia and ischemia. So when we talk about previa, if the placenta is too close to the cervix, the baby's head can compress the cord, leading to decreased blood flow. So it's going on to the cord and on to the actual placenta, right? And so, the cord inserts into the placenta and then into the baby. So with previa, if we want our, placenta up high here away from the baby, and the placenta is actually down low and really close to the cervix, the baby's job, right, towards delivery is to get close to the cervix and to be ripening it for delivery. So we just don't want it to get down there where the baby can kind of sit on it and compress it. So compressing of the cord and the placenta during placenta previa puts the baby at risk. Abruption is when the placenta partly or completely separates from the inner wall of the uterus. So this is kind of like a tearing. I have this lovely wound on my finger from opening a cat food can last week, and it's split apart. And that's essentially what's happening, is the placenta is splitting apart from the uterus. And then we are in severe deprivation of oxygen and nutrients. Placental abruption is one of the main causes of HIE. Accreta, now if we think about accretas and percretas and incretas, all of those things kind of come together just to say that the placenta has inappropriately attached to the uterus. And the deeper it's attached and then it goes into the uterine wall, it might even escape out the uterine wall, you can imagine that the placenta is not going to function as well as it would if it were just nicely adhered. When you really get it through the muscle of the uterus and then the uterus does its job of contractions, you can see, oh my gosh, now the placenta is having pressure put on it. So accreta, also, if you really get percreta, we're getting to these places where these babies are also delivered often in a main OR as opposed to a labor and delivery OR. And anytime you kind of have a delivery outside of a normal location, the baby's also at risk. So it's kind of this double whammy. So now if we talk about the cord specifically, so we're talking about the umbilical cord, that lifeline, this blood supply between the mom and the baby. If anything impedes this blood flow, it's going to put the baby at higher risk. So nuchal cord is when the cord is wrapped around the baby's neck, as in this picture here. You'll hear them say nuchal times 1, nuchal times 2. That's the number of times it's wrapped around. True knots is when the baby has swam and tied knots into their own cord. It's pretty wild. And it gets tighter and tighter and tighter, and then it's impeding the blood flow. Marginal cord insertion is the location of the cord inserting onto the placenta, and that puts the baby at risk for this gas exchange and the blood flow through there. You can also have cord compression that can happen with LGA babies, with multiples that are sharing the same sac, so mono twins that have one placenta and one sac. Those babies are at risk because one baby will lay on the other baby's cord. So when we talk about the uterus, obviously the uterus is this house, right? It is holding this temporary sac with the placenta and the umbilical cord and the baby, that any damage that's done to it would put the baby at risk. So uterine rupture and previous C-section. So if your uterus has already been injured from the incision, it's going to put the baby at higher risk for having a uterine rupture or having your uterus not function as well. You could have infection, and then of course our incretas and percretas factor into this as well. But really that uterine rupture, which most often happens after a previous C-section, and so that's why they call, if you are doing a TOLAC, so trial of labor after cesarean, to kind of see how your uterus is handling that. Or if you have a previous C-section, you may just be scheduled for another one. That's kind of why, is because this is an incision that's happened into a muscle, and then that muscle is stretched, and then when the contractions are happening, it stretches and contracts and stretches and contracts, and it can rip and tear apart. Another very high risk for HIE. Placental abruption, uterine rupture, we think of those two being really close together as far as the complications. And then, of course, we have our labor and delivery complications, or things that are going on with the mom. So if we kind of put the prolonged labor, the extensive pushing, and the C-section after pushing together, this is the idea that the placenta, this temporary organ, is having a lot of pressure put on it, and then the baby is also getting tired from the contractions that are happening. If a mom pushes for an extensive period of time and then goes to a C-section, that is considered high risk because we would assume that the baby is already in a state of distress. So if the mom has trialed pushing and been unsuccessful, That is one of the reasons that as a NICU team, we would be attending the delivery. The prolonged labor where the mom has been in labor for an extensive amount of time. Again, the placenta is tired, the baby's tired, all the pushing. When you think about a meconium delivery, so remember, meconium is not a normal finding at delivery. So if there's been meconium, that means that the baby has been under a period of stress. So meconium comes out when the baby is stressed. So it just tells you that things were not going well in there. An instrumented delivery, so a vacuum and forceps, put the baby at high risk. And I like to think about the why. Why are we at a place where we need instrumented delivery? That should tell us a lot about what's going on with the baby. Is it because of inefficient pushing? Is it because the mom is tired? Is it because the baby's having D cells? There's not a reason. Now, I know back in the day, they used to just like put forceps on babies all the time, back in the 60s and all of that. Wild times. Watch Mad Men. That's where I learned about that, and call the midwife. But I digress. These instrumented deliveries are not just like normal practice anymore. So if a mom has gotten to a place where she needs an instrumented delivery, it tells us that something was going on. The shoulder dystocia, the LGA, the postdates, those also all kind of go together in this idea that maybe we just have a baby that's too big for the canal, and maybe an alternative form of delivery. I also want to talk about postdates a little bit because that comes back to our old friend, the placenta. The placenta is a temporary organ. So if we are past its kind of due date, its expiration, it's not going to function as well as it did at the beginning of pregnancy. So that puts extra strain on the baby as well. Oligo, when the baby just doesn't have enough room. Why do we have low fluid? What is going on? And again, that risk for cord compression. Any hemorrhaging that the mom's experienced, even help preeclampsia. And again, this is not an exhaustive list. I have not listed every single thing that could possibly go wrong during labor and delivery, but these are the big ones. I think when I think of all the reasons I've seen a baby admitted for HIE that we end up doing total body cooling for, placental abruption, uterine rupture, severe nuchal cord, and then instrumented delivery and shoulder dystocia tend to be the biggest reasons that we see. So with shoulder dystocia, when you're just kind of stuck in there, you're going to lose that blood supply and that oxygen supply. So those are the ones that kind of jump out to me the most. Obviously, all of these are very important. But again, this is not a complete list. And it doesn't mean that every time these happen that the baby will have HIE. That's why HIE is one of the tricky diagnoses. So when providers are looking at diagnosing a baby with HIE and getting neurology involved, they're asking themselves, did the infant have an antenatal event? What was our 5-minute APGAR? What is our cord gas? What does the baby look like? What is our neurological exam telling us? There's a Sarnart classification of HIE that really kind of lays out each thing. And in my opinion and in my experience, it's easy to see the babies that have severe HIE. They are easy to identify. They are usually extremely sick, flaccid, no reflexes, no tone, no suck, no gag, nothing. They're intubated. They're in DIC. It's really bad. The difference between mild and moderate tends to be a little blurrier. A lot of their signs are kind of similar. And so this is when you're relying on some kind of scoring system to kind of go through and evaluate each thing. And that's what the providers would be doing. Either your doctors or your nurse practitioners are going to kind of go through and say, okay, what is our movement? What is our tone? What is our reflexes? And they give them a score. And when you total up that score, it tells you how at risk they are. Do we need to get neurology involved? What would that look like? So this is all the things that we're looking at. HIE is definitively diagnosed with the conjunction of a neurologist, an MRI, looking at EEG for seizures. You cannot have seizures and you can still have HIE. So looking at kind of the damage in that MRI, getting the baby down to MRI after they rewarm if they're cooling is going to be key to understanding the extent of the damage from HIE. So our current evidence-based practice is kind of taking all of that and deciding on who we should cool for HIE. So do they have an antenatal event? Was there placental abruption, a nuchal cord, etc.? Is the baby greater than 36 weeks and 1,800 grams? Those are the biggest markers right now. There's lots of evidence about cooling smaller and younger babies, but right now the best evidence-based practice tells us 36 weeks and 1,800 grams. Is the baby less than 6 hours old, which we're going to go into a lot next week about why that 6-hour window is so important. What is our APGAR score at 5 minutes? So oftentimes our first AFGAR is not great, but if we can get some resuscitation going, the baby kind of turns around. If by 5 minutes the baby hasn't turned around, we should be concerned. Our cord gas tells us so much, and it's so important. Our cord gas tells us what the baby was experiencing in utero. What were they swimming in? What were they receiving? What was their carbon dioxide? What was their oxygen? Our first gas is helpful, especially if you're looking at the base deficit, because that takes much longer to correct. But when you're looking at that initial gas, it's often telling us how good we were at resuscitating or how good we are at ventilating. So in the presence of being at risk for HIE, getting a cord gas is going to be imperative. But if you can think, if the mom is hemorrhaging, if the baby, or if there's a placental abruption or uterine rupture, what if the blood flow is terrible? One thing I didn't put on the risk for mom baby is a amniotic embolism. We've seen 2 cases of that in the last 5 years, that the baby had HIE because the mom had an amniotic embolism. So again, those situations, the baby is in a lot of distress. The mom's in distress. We might not have the best blood flow to get that cord gas. And then we're looking at, does the baby have moderate encephalopathy? Again, there are studies coming forward about cooling babies that have mild, but right now we really are looking at that moderate encephalopathy, and of course the provider's discretion as to kind of putting all these risks together. So we're going to close today's Teach Me Tuesday just talking a little bit about HIE and educating our parents. So most these babies have made it to term, right? 36 weeks or greater. Some of them are 40, 41 weeks. Maybe they've had a very uncomplicated pregnancy. Maybe they don't even know what the NICU is. And then they get this unexpected admission and a diagnosis that can be devastating. So we need to prepare parents for what they will see. What is the NICU going to look like? What's their baby going to look like? Are they having seizures? Is the baby moving? Is the baby not moving? Let's get bonding going. Let's get some touch going, touch hold, changing the diaper, checking the temperature, whatever we can do, smells to help the mom and infant and parents bond. Inform them of when rounds occur on your unit. Make sure that they are there when the neurologist is there so they can explain what they are seeing and doing. Explain the next steps. Is that going to be cooling? Is that going to be an EEG? Are we going to get central line? What does our medication look like? Do we need consent for blood because the baby is in DIC? So much is happening in these first few hours when most parents are assuming that they would just be bonding with their baby. So it is so traumatic. All I think about when I think about HIE admissions are trauma. But then getting the mom also to provide breast milk in the setting that we would want to be using that as soon as we can. So this first part of this HIE conversation is really about understanding how complicated this diagnosis is, looking at the risk factors, knowing that we don't know just from looking at the admission the extent of the damage from the antenatal event. I have seen babies that I thought would be devastated. I can think of one right now off the top of my head that happened about 5 or 6 years ago. I remember looking at him thinking, he's not going to make it out of here. He was completely non-reactive. He was completely vent dependent, could not control his blood sugars, all of these things. And he left breastfeeding. I mean, I remember when he left, I'll never forget. It was like my mind was blown. So we just don't know from looking at them until we really get that MRI report. We get them cooled and we rewarm them to see where they are. So looking to recognize the warning signs and having standards of practice in place can minimize those delays in care. If you're the admit nurse that day, the admit team, and you pay attention to those warnings, like, okay, oh yeah, they're going up on a meconium, they're going up on an abruption, it's a code white, it's a code blue, those things are going to clue you into, hey, this could be a really sick kid with HIE. So next week we're going to dive into treatment options, including cooling, and we're going to talk about other treatments that they've looked into and what the goals of all these therapies are. So almost made it. Thank you for joining me for this Teach Me Tuesday. Of course, please like and subscribe so that you can know when new videos are coming out. Post any questions you have, or please feel free to reach out to me via email. I hope you have a great day, and I will see you next week.